Welcome to this presentation on antithrombotic agents, commonly referred to as blood thinners. In this session, we will cover the types of antithrombotic drugs, their mechanisms, and important side effects. This knowledge is key in understanding how we manage and prevent blood clots in various medical conditions. Antithrombotic agents are divided into three main classes. First, antiplatelet agents, which prevent platelets from clumping together. Second, anticoagulants, which interfere with the clotting cascade to prevent fibrin clot formation. And third, thrombolytics, which actively dissolve existing clots. Each of these classes plays a distinct role depending on the clinical scenario. Platelet plug formation is the foundation of how clots begin to form. After a blood vessel injury, platelets adhere to exposed collagen via von Willebrand factor, become activated, and release signaling molecules like ADP and thromboxane A2. These chemicals attract and activate more platelets, which then aggregate through GP2B3A receptors, forming a temporary platelet plug. Antiplatelet drugs are classified based on their molecular targets. Aspirin inhibits cyclooxygenase 1, COX-1, thereby reducing thromboxane A2 production, a key mediator of platelet activation. ADP receptor blockers, such as clopidogrel, inhibit the P2Y12 receptor, preventing ADP-mediated platelet activation. Glycoprotein 2B3A inhibitors block the final common pathway of platelet aggregation by preventing fibrinogen binding. PAR1 inhibitors prevent thrombin-induced platelet activation. Additionally, phosphodiesterase 3, PDE3, inhibitors, like cilostazol and dipyridamole, increase intracellular CAMP levels in platelets, leading to reduced platelet aggregation and vasodilation. Aspirin irreversibly inhibits COX-1, reducing the production of thromboxane A2, a potent platelet activator. This mechanism makes aspirin effective in preventing arterial thrombosis. Low-dose aspirin is commonly used for primary and secondary prevention of heart attacks and strokes, particularly in patients with atherosclerotic disease. However, it carries risks, including gastrointestinal bleeding and ulcers. Drugs like clopidogrel, prasugrel, and ticagrelor block the P2Y12 receptor, preventing ADP from activating platelets. This reduces the expression of GP2B3A receptors, thereby decreasing platelet aggregation. These agents are commonly used in acute coronary syndromes and after coronary stent placement as part of dual antiplatelet therapy with aspirin. GP2B3A inhibitors, such as abciximab and eptifibatide, block the final common step of platelet aggregation, fibrinogen binding to activated platelets. They are administered intravenously during high-risk procedures like percutaneous coronary intervention. Due to their potency, they are reserved for short-term use in hospital settings. Bleeding and thrombocytopenia are notable risks. To understand how PDE3 inhibitors work, we first need to understand the role of CAMP in platelets. CAMP acts like an internal brake. When its levels are high, it prevents platelets from becoming fully activated. It does this by reducing intracellular calcium release, which is essential for shape change, granule secretion, and aggregation. So, higher CAMP levels mean reduced platelet activity and less clot formation. Phosphodiesterase 3, or PDE3, normally breaks down CAMP. When we inhibit PDE3, CAMP levels remain elevated, helping to keep platelet activation under control. PDE3 inhibitors are a unique class of antiplatelet drugs that work by increasing CAMP levels in platelets, thereby reducing platelet activation. The two main drugs in this class are cilostazol and dipyridamole. Cilostazol is commonly used in patients with intermittent claudication due to peripheral artery disease. It improves walking distance by promoting vasodilation and reducing platelet aggregation. It's also used off-label in some stroke prevention settings. Dipyridamole is usually combined with aspirin to prevent strokes, especially in patients with a history of transient ischemic attacks. It also plays a role in cardiac stress testing due to its vasodilating effects. Both drugs may cause headache, hypotension, and palpitations due to their vasodilatory properties. While not first-line agents, PDE3 inhibitors offer important benefits in selected patient populations. Vorapaxar is a PAR1 antagonist that blocks thrombin-induced platelet activation. It's used for secondary prevention in patients with a history of myocardial infarction or peripheral artery disease. Due to its high bleeding risk, especially in patients with prior stroke or TIA, it must be prescribed with great caution. Before diving into anticoagulants, it's essential to understand the coagulation cascade. It begins with two pathways, the intrinsic and extrinsic pathways. Both converge into the common pathway, where factor X is activated to factor Xa. Factor Xa then converts prothrombin, factor II, into thrombin, factor IIa, which in turn converts fibrinogen into fibrin, forming a stable clot. Different classes of anticoagulants target specific steps within this cascade. Anticoagulants work by interrupting the coagulation cascade, preventing the formation of a fibrin clot. They are essential in managing conditions like deep vein thrombosis, pulmonary embolism, atrial fibrillation, and in patients with mechanical heart valves. The main classes include heparins, which enhance antithrombin activity, vitamin K antagonists like warfarin, which inhibit synthesis of clotting factors, and direct oral anticoagulants, also known as DOACs, that directly inhibit factor Xa or thrombin. Heparins are a major class of anticoagulants that enhance the activity of antithrombin 3, which inhibits clotting factors such as factor Xa and thrombin, factor IIa. Unfractionated heparin inhibits both factor Xa and thrombin equally, is administered intravenously, and requires close monitoring with activated partial thromboplastin time due to its variable response and shorter half-life. In contrast, low molecular weight heparins, like enoxaparin, preferentially inhibit factor Xa, are given subcutaneously, and typically do not require routine laboratory monitoring because of their predictable pharmacokinetics. Fondaparinux, a synthetic pentasaccharide, selectively inhibits factor Xa by binding to antithrombin 3 without affecting thrombin. It is administered subcutaneously, has a long half-life allowing once-daily dosing, and carries a lower risk of heparin-induced thrombocytopenia, HIT, making it a safer option for certain patients. Warfarin is a vitamin K antagonist that inhibits the synthesis of vitamin K, dependent clotting factors 2, 7, 9, and 10. Due to its delayed onset of action, it is often initiated alongside heparin to provide immediate anticoagulation until a therapeutic effect is achieved. Warfarin therapy is monitored using the prothrombin time, PT, standardized as the International Normalized Ratio, INR, to ensure effective and safe dosing. Its anticoagulant effect can be significantly influenced by dietary vitamin K intake and numerous drug interactions. Additionally, warfarin is teratogenic and therefore contraindicated during pregnancy. Direct oral anticoagulants, DOACs, are classified into two main groups: direct thrombin inhibitors, such as dabigatran, and factor Xa inhibitors, including rivaroxaban and apixaban. These agents are taken orally, have predictable pharmacokinetics, and do not require routine laboratory monitoring, making them a convenient alternative to warfarin. DOACs are widely used for conditions such as atrial fibrillation and venous thromboembolism, but they should be avoided in patients with severe renal impairment due to reduced clearance. Their primary adverse effect is bleeding, though specific reversal agents are available for some agents, enhancing their safety profile in emergency situations. Thrombolytics, also known as fibrinolytics, are used to actively dissolve existing blood clots, in contrast to anticoagulants, which primarily prevent new clot formation. They work by converting plasminogen into plasmin, an enzyme that breaks down fibrin, the structural component of a clot. Commonly used agents include alteplase, retiplase, and tenecteplase. These drugs are life-saving in acute conditions such as ST elevation myocardial infarction, STEMI, ischemic stroke, and massive pulmonary embolism. However, due to their potent fibrinolytic activity, they carry a significant risk of bleeding, particularly intracranial hemorrhage. As a result, they are contraindicated in patients with recent surgery, trauma, or a history of hemorrhagic stroke. Warfarin has several important contraindications and requires careful monitoring. It is contraindicated in pregnancy due to its teratogenic effects and should be avoided in patients with active bleeding, recent high-risk surgeries, or uncontrolled hypertension. Warfarin is highly sensitive to interactions with cytochrome P450, CYP450, enzymes. CYP450 inhibitors, such as amiodarone, fluconazole, and erythromycin, can increase warfarin levels, heightening the risk of bleeding. Conversely, CYP450 inducers like rifampin, carbamazepine, and phenytoin can reduce warfarin efficacy, increasing the risk of thrombosis. Because of these interactions and its narrow therapeutic window, regular monitoring of the prothrombin time and international normalized ratio, PT and INR, is essential to maintain safe and effective anticoagulation. Clopidogrel is a prodrug that requires metabolic activation in the liver, primarily by the CYP2C19 enzyme. Inhibition of this enzyme by drugs such as omeprazole, esomeprazole, and fluoxetine can impair clopidogrel activation, reducing its antiplatelet effectiveness and increasing the risk of thrombotic events. Additionally, genetic variability significantly affects response. Individuals who are poor metabolizers due to CYP2C19 polymorphisms may not convert clopidogrel efficiently. In such cases, alternative agents like prasugrel or ticagrelor, both of which do not depend on CYP2C19 for activation, are often preferred to ensure adequate platelet inhibition. In summary, antithrombotic therapy encompasses antiplatelets, anticoagulants, and thrombolytics, each with distinct mechanisms of action, clinical indications, and risk profiles. A thorough understanding of their pharmacologic targets, appropriate uses, potential adverse effects, and drug interactions is crucial for ensuring safe and effective treatment. When used correctly, these agents can be life-saving, but they demand careful monitoring and vigilant management to minimize complications and optimize patient outcomes.